Welcome to fabulous Las Vegas, but more importantly, welcome to the 28th Cervical Spine Research Society Instructional Course Lecture. My name is Michael. My name is Jason Savage from the Cleveland Clinic, and I have the pleasure of co-chairing this session with Max Mayoki from University of Louisville.
Thanks, Jason. We have a couple of short talks, and then we'll go into a case debate. Next up, Dr. Brandon Lawrence on pros and cons of crossing the cervical-thoracic junction.
All right, welcome everybody, and thank you CSRS for having this ICL and inviting me to speak at it, and also not recording my presentation this year and actually being here to present. So here we are again. So I was asked to talk about crossing the cervico-thoracic junction, to cross or not to cross. It's interesting as we sort of, and these are my disclosures, nothing pertinent to this talk. But it's interesting as we sort of get into, why we do certain things. I'm going to show a case presentation in the middle of this that sort of talks about common things being common. And with that said, a lot of the time we have to use common sense in order to make certain decisions. And there's certain things that you'll see on radiographic films and parameters and findings that sort of will lead you in one way or another. And so I think as you start to consider crossing the cervico-thoracic junction or stopping at C7, there's a lot of things that will kind of push you in one way or another. And what I'll commonly say to our trainees and residents and fellows is, anybody who ever says, I always do this or I always do that, just be a little bit careful. You have to, make decisions based on what the patient needs. And I don't think that, and you'll see as we get through this literature here, I don't think that you'll see really good evidence that one way is better than another. And as we sort of talk about some of the studies today, you'll see that there's a recent uptick in interest in the cervico-thoracic junction, probably driven from some of the deformity that you'll hear about later today. But it's the looking at the radiographic differences and the outcome differences between stopping at C7 versus crossing that junction, is controversial. So we'll talk about that a little bit today. And then we'll finish up with my case and sort of like what I think about and how I decide. So as we look at this and we try to understand what the problem is when we stop at C7, there's a lot of literature out there, and the thought is that we may be increasing adjacent segment problems, markedly distal adjacent segment problems, the C7-T1 issues. We may have less radiographic correction when we stop at C7, but, these are different pathologies when you cross that cervico-thoracic junction versus stopping at C7. And some of the literature, it's controversial again, and you can pick studies to sort of defend one way or the other if you want. But when we look at the patient-reported outcomes, they may be better if you stop at C7, but these pathologies are completely different when you stop at C7 versus cross that junction. A lot of the time, you're trying to fix deformity, or you're trying to do more with the patient when you're crossing that junction versus when you're stopping at C7, and that may in and of itself dictate one way or the other. As we start thinking about now crossing the cervico-thoracic junction, maybe you decrease adjacent segment problems. The more you fuse, the less problems you'll have. You may trade those for non-unions, but you will decrease your adjacent segment problems. You may have less reoperations when you do that. And again, patient-reported outcomes, they may be worse, but again, these are different pathologies you're treating. So, when I think about crossing that cervico-thoracic junction, I think about it in a very similar way to crossing the lumbosacral junction. If you need to cross it, you should cross it. If you can stop at C7, it's okay to do that. And when you think about crossing that lumbosacral junction, it is a different pathology you're treating. And so keep that in mind as we sort of go through this literature. So this is the case. This is a 77-year-old female. She was 8 years status post with thoracolumbar fusion. She had done quite well over the years, but then started having issues that are consistent with myelopathic findings, especially in the last several months. She started getting a lot worse with balance and dexterity issues. She had no consistent radicular pattern. She had no C8 symptoms. Those are all things that obviously you're trying to distill when you're talking to these patients. But these are her Scoli films, which you can see. she's 77, her C7 plumb line or her sagittal vertical axis is about 8, so it's age matched. And so this isn't a deformity patient. This is just a patient coming in with myelopathy. And this is a patient, I picked one from last week. This is a common problem that we see. As we look at this flexion and extension views, you can see that she has pretty decent mobility. If you look down lower, though, you can see that she's got a small C7T1 spondylolisthesis as well, and so that's one of the things you want to make sure you look at and try to understand when you're trying to figure out, can you stop at C7 or cross this junction? As you look at her MRI, she's got multi-level stenosis starting at C3-4. C4-5 looks okay, but then C5-6 and C6-7 has pretty significant stenosis with some subtle cord signal change. And then down at C7T1, the canal is pretty open. She's got some foraminal stenosis, but again, no radicular symptoms. As we start to look at the literature for this, you can see over the last several years, there's been a lot of interest in looking at the cervicothoracic junction, and especially in the last 7 or 8 years, you can see a lot more publications when you search in PubMed. And one of the studies, there's a recent review from, a little shout out to one of my prior residents, Myelopathy. This is a great review to look at for any residents and fellows in the room. Just reviewing the current literature and really understanding the differences between crossing the cervicothoracic junction or not. And when we get into, and I picked 3 of the recent studies. Again, you can go through the literature and decide one way or the other, but 3 of the more recent studies here is this first study, a systematic review and a meta-analysis of patients who had crossed the cervicothoracic junction or stopped at C7. They started with a couple thousand publications and ended up with 8. When you look at their sort of outcomes, you can see, as you would expect, hospital stay is less than the C7 group, blood loss is less than the C7 group, and OR time is less than the C7 group. That's not a surprise. When you look at the differences between adjacent segment problems and reoperation, though, you can see that the crossing that cervicothoracic junction seems to be favored, meaning less adjacent segment problems as well as less reoperations. Hardware failure there's no benefit one way or the other looking at all of these studies, as well as postoperative hematoma. But when you look at, go back one slide here. I can't go back. Yeah, there we go. But when you look at, these are really the findings that we're most interested in. And when you look at these two, it does appear as though, and for the same reasons I already discussed, that there is less adjacent segment disease and reoperations. Another study by the Rothman group, this is 160 patients, so it's quite a few patients in here. They had 92 patients that crossed the cervicothoracic junction, and what they found was that there was no real difference in patient-reported outcomes either way. Revision rates were significantly different, though, and when you look at the overall patient cohort, it was a 8.8% versus 1% revision rate in the C7 group versus the cervicothoracic junction group. And then they did a subgroup analysis again, and this was just the C3 to 7 versus the C3 to T1 group. And there were no patient-reported outcome advantages either way, but there were significant differences in revision rates, 15% versus almost 2%. Last study that we'll sort of talk about, this is another study, a little less patients, but this was just published in June. This was 66 consecutive patients that they looked at. They put in this age-matched control group, which is less important for this discussion, but they had 36 patients that they had stopped at C7, and then 30 that crossed that cervicothoracic junction. It's a single institution retrospective study, and what they showed was that there were significant differences in radiographic parameters, and change in the T1 slope was significantly higher in the cervicothoracic junction group, as well as the cervical lordosis change, looking at these two groups. Finally, that change in the cervical sagittal vertical axis was also more improved significantly in that cervicothoracic junction group. And then looking at the patient-reported outcomes, again, different patient populations. So you can sort of defend one way or the other, but there were increased improvements in patient-reported outcomes in the C7 versus the cervicothoracic junction group. So, To get back to our case, this is a patient, multi-level cervical stenosis, C17 spondylolisthesis. For me, I did a C3 to 7 laminectomy, and then did a C3 to T1 posterior instrumented fusion. I think this is a very classic example of the kinds of patients that we see pretty regularly. And trying to make those decisions as to when to stop at C7 or not is sort of up to you moving forward. As we kind of get into conclusions, do what you need to do for each patient, evaluate instability, make sure that there's anatomic favorability for C7 pedicle screws, and if you're shooting to improve alignment, make sure you get Scoliosis films. Stopping or crossing remains controversial, as we talked about. And then finally, prospective studies are difficult because these are two patient populations, and deciding to cross or not to cross need to be tailored, and each patient deserves that consideration. Thank you very much.